Hi, my name is Melissa and I am an occupational therapy student at the College of St. Mary. Today I'm going to be talking to you about shoulder pain in the hemiplegic shoulder. Researchers have come up with a lot of theories and ideas as to what causes hemiplegic shoulder pain. So in this presentation, I'm going to talk about a couple of the potential causes as well as some interventions that therapists can do in order to alleviate shoulder pain in their clients with hemiplegia. The shoulder joint of the upper extremity is where the humeral head meets the scapular glenoid fossa. The humeral head is held into place in the fossa by the four rotator cuff muscles: subscapularis, supraspinatus, infraspinatus, and teres minor. Many of the causes of shoulder pain are thought to be associated with these four muscles, specifically the subscapularis muscle. There are many potential causes for hemiplegic shoulder pain. However, in this presentation, I will focus on subluxation and abnormal muscle tone. In the past, subluxation has often been thought to be the primary cause of shoulder pain in the hemiplegic shoulder. Subluxation is caused by changes at the shoulder joint that result in a palpable gap between the humeral head and the acromion of the scapula. Post-stroke, the arm is flaccid because of a loss of deep tendon muscle reflexes and muscle tone. The lack of active motor function at the rotator cuff muscles results in a downward drift or inferior subluxation of the humeral head. However, current research points to subluxation as not being a primary cause of hemiplegic shoulder pain. Abnormal muscle tone post-stroke is considered to be one of the primary causes for hemiplegic shoulder pain. An example of abnormal tone would be spasticity, or velocity-dependent increase in muscle tone on the affected side in response to passive stretch. Abnormal tone disrupts the scapulohumeral rhythm and contributes largely to the hemiplegic posture seen in clients post-stroke. For example, the increased tone of the subscapularis results in shoulder adduction and internal rotation. Since most functional activities require shoulder abduction and external rotation, this increase in tone often contributes to extreme pain during functional activities. Based on the current research, it is my opinion that since most functional activities involve external rotation and abduction, such as washing hair or brushing teeth, the most likely cause for hemiplegic shoulder pain is spasticity at the muscles involved in internal rotation and adduction, such as latissimus dorsi, pectoralis major, teres major, and as previously discussed, the subscapularis muscle. Now that we have discussed some potential causes for hemiplegic shoulder pain, I'm going to talk about two interventions that occupational therapists can do in order to prevent or reduce the amount of hemiplegic shoulder pain seen in their clients. The first intervention is to educate the client and caregiver on proper positioning and handling techniques. When positioning a client, make sure their arm is supported at rest. Also, avoid static positioning of the upper extremity in internal rotation or adduction. Instead, place the arm in a forward position with a protracted scapula, flexed shoulder, and extended elbow. Also, when helping the client move, assist the client through the scapula and the trunk, and never pull on the affected arm or lift the client from under the arms. Also, be sure to educate the client, caregiver, and staff on proper positioning and handling techniques in order to reduce shoulder pain and prevent further injury to the affected arm. The second intervention I'm going to talk about is promoting pain-free passive range of motion at the scapula and shoulder joints in order to help promote return of functional range of motion at these joints, as well as helping get the client out of the hemiplegic posture often seen post-stroke. Increasing passive range of motion is essential in preventing joint stiffness and contractures. It is also the first step in regaining or maintaining pain-free functional range of motion that will help improve or promote the client's ability in performing ADLs. Also be sure to respect pain and never force range of motion. Instead, only range to where the resistance is felt, never further. Begin with passive range of motion of the scapula, as this is the starting point for the range of motion of the shoulder joint. Be sure to start with scapular elevation, then move to protraction during forward flexion of the upper extremity to less than 90 degrees, and finally, move to upward rotation once elevation and protraction are regained. In conclusion, there are many possible causes for hemiplegic shoulder pain. However, I feel the most likely causes are spasticity as well as the posture associated with many people who have hemiplegia. Therefore, I feel the most beneficial interventions would be teaching the client and caregiver about proper bed, wheelchair, and chair positioning in order to support the hemiplegic arm, as well as increasing passive range of motion in the shoulder joint. Thank you for watching my presentation.